topic today differs from what you sent me, and I'll explain why in just
Recording in progress.
All right. Sorry, just 1 second. Let's try this again. So you'll notice that my topic today differs from what you were expecting for a couple of reasons. So first of all, CNS neoplasia, I actually won't give that lecture because I'll let the surgeons deal with that lecture. So what I did is I did next week Tuesday's lecture, and that's the one I'm going to give instead. And so, so for CNS neoplasia, I'll just ask the surgeons to go ahead because I know you'll have a series at some point. The reason I'm doing this is because they are mainly the people concerned with managing this. And so what I would have given you would be a medical approach to CNS neoplasia, which will be not so useful at level 4. Maybe in level 6, that would be more useful because we'll go and get more of the drugs and available and the imaging. So at this point in time, I'll let this be covered under your surgical series. So I'll move straight on to peripheral neuropathy and go ahead. I think somebody's mic is on. If you wanted to speak, go ahead. Okay, so I'll spend the next few 40 minutes talking about peripheral neuropathy. I believe I can be heard. Sometimes I mumble, so if I'm mumbling, please let me know. Once again, if you have questions, you can share them in the chat box, and if I can deal with them as we go along, that would be great. If not, so by way of outline, this is what we'll be looking at over the next few minutes. Sorry, a few things because there are a few things in my way. And it won't be a very long lecture. So what is peripheral neuropathy? Well, peripheral neuropathy, that's actually where I should have started before I go to this. Really, if we think about the central nervous system and the peripheral nervous system, when we talk about the central nervous system, we're talking brain and spinal cord. However, when we talk about the peripheral nervous system, we are talking about everything from right outside the nucleus of nerves to where it's giving you nerve fibers. So if we think in terms of cranial nerves, we're within the brain where we have the nuclei. Remember, cranial nerve 1 to 4 on the midbrain, and then 5, 6, 7, and 8 were in the pons, and then we move down from 9 to 12, and that was more in the medulla. So all those are considered central areas because that's where their nuclei emerge from. But once they start getting out the nerve fibers, we consider that more of a peripheral nerve. And so that's why people who have nerve palsies can end up, we consider that peripheral neuropathy because it's an irritation of the nerve right around the facial canal. And so that's considered a peripheral neuropathy, okay, even though it's in a cranial nerve. So likewise, when we think about the spinal cord, once we get the nerve roots getting out of the spinal cord, then that is considered a peripheral nerve. And so we go from the nerve roots to the actual nerve fibers. And that's all part of peripheral nerve. So that said, okay, my voice keeps fading out. Okay, I've been told that sometimes that happens. Let me try and use my hands free because sometimes. Thank you for your feedback. Give me just 1 second. All right. Okay, so you let me know if this is any different because right now I'm using my headset and I've been told that sometimes that helps. Okay, let's see if it's helping. Way better. Okay, thank you very much. All right. Thank you so much. All right, so by way of introduction, if I could get back there, why is it important? Well, the prevalence of peripheral neuropathy approaches about 10%, but is much higher in certain disease entities. So when we're talking about a prevalence, we're talking about if we took the whole community and just asked how many of you people have, positive or negative feelings in your, long nerves or in your hands and your feet, would be 10%. But when we go with specific disease entities, that prevalence can approach 80 to 90%, okay? So it can be challenging to identify an underlying cause. And you'll notice that there are lots of diseases that can cause peripheral neuropathy. And so it can be quite a challenge to identify an underlying cause. And so sometimes just a structured approach is both efficient and economical, both in terms of your time and in terms of your knowledge and how to structure the approach to peripheral neuropathy. So first you want to localize where in the nerve is it? If it's coming from the spinal cord, is it at the nerve roots? Is it going right down to the axons? Or is it already in the peripheral nerve fibers? Likewise, you want to characterize. You've heard me already use the terms, whether it's positive symptoms, which would be things like burning, tingling, pins and needles, or whether it's mostly negative symptoms, which would be things like numbness, lack of awareness, desensitivity, coldness. So those would all be negative symptoms, your inability to feel. It also helps if you want to come up with differentials, because that helps you also in terms of investigating. And like we've said, there's so many things that can cause this. So if you come up with your possible differentials, it makes your investigation path much, much simpler or much more rational. And then last but not least, I've said the term, I think 4 times now, lots of things can cause peripheral neuropathy. So when you're doing these tests for the different things, we try to rationalize it because it makes economical sense to do that. And we try to do it in a more structured approach. So that's it. How do these nerves get injured? Well, there are 4 main mechanisms. If we think of the nerve as a long electrical cord, which is covered by insulation, okay, and the insulation is what we're calling the myelin, and the long electrical fibers is what we're calling the axon. So the myelin sort of helps with nerve conduction and helps with propagation of nerve conduction. And when we remove that covering, when you have demyelination, then the propagation along the electrical wire is interrupted. So just think of it like electricity. So when you have a nerve that is transected with both the actual wire and its covering being transected, then you have degeneration of the distal segment. So further down, you will have degeneration. And that's what we call Wallerian degeneration. So that is usually the most severe form, because as you can imagine, you've cut off, all form of life and neuronal transmission, because you've got not just through the coverings, which is the myelin, but through the actual nerve, which is the axon. The second main mechanism is axonal degeneropathy. Axonal degeneration, or what we call axonopathy. That was me creating a new word. So with this one, we have distal axon loss. So the covering of your nerve remains quite intact, but due to things like toxins or diseases like diabetes, you actually have the nerve fiber going through loss, and it goes through degeneration over time. So it's not sudden. And this would happen, and it's quite common in metabolic disorders. And for some reason, it tends to start with more of the sensory nerves first. Okay, so we remember from our neuroanatomy that there were some nerves that had both motor and sensory fibers. There were some that were purely sensory, and there were some that were mixed. So for some reason, axonal degeneration, especially in metabolic disorders, happens more in the sensory nerves for disorders like diabetes, but it can also happen in purely motor nerves. And then you have a third pathologic mechanism. So this is when we have at the spinal cord level, you remember the anterior horn cells were what was involved in formation of both your motor fibers. And so when you have nuclear degeneration at that level, we call that a neuronopathy, all right? And so this happens within the spinal cord, but it can also happen in sensory nerves within the dorsal root ganglion. So certain disease processes that can give you a neuronopathy would be things like motor neuron disease, which would be at the anterior horn cells of the spinal cord, or paraneoplastic disease, or even some autoimmune disease can give you a type of neuronopathy. The last type of pathologic mechanism, which I'll talk about, is segmental demyelination. And as the name suggests, we said the nerves have both a covering and the meat, okay? So this is when the covering of the nerve is interfered with. So if you have an electrical wire and you cut off some of that insulation, then you have some form of demyelination. And this happens due to direct damage to the myelin sheath. And some diseases that can cause this include Guillain-Barre syndrome or other types of demyelinating disease like CIDP. Now, when we have demyelination within the central nervous system, we come up with disease processes like multiple sclerosis or like ADEM, and all those are affecting the covering of the nerves, but within the central nervous system. So those explain some mechanisms, but we also have different patterns of peripheral neuropathy. And like we've said, once we are involving a peripheral nerve, it could be a single nerve, and we'd call that a mononeuropathy. So that can happen likely due to trauma or due to compression. A very common mononeuropathy is when you compress the median nerve at the wrist. So that's what's commonly called a carpal tunnel syndrome. So it's a single nerve, a peripheral nerve, it's compressed at a peripheral site at the wrist. So that would be considered a mononeuropathy. Whereas when we have many nerve cells affected, which are regardless of the nerve, okay, and usually happening in a very symmetrical way. So when we think about patients with diabetes who describe burning in their feet or a numbness in their feet, either positive or negative symptoms, then we consider that a polyneuropathy because it's affecting many different nerve cells regardless of the nerve, and it's usually quite symmetrical. So this can affect, like we've said, axons, or it can also affect the myelin, or it can affect cell bodies. So the thing about polyneuropathy is it's usually quite symmetrical. So burning in both feet is what we'd call a polyneuropathy. Okay, if it's asymmetrical, then that is less likely to be a polyneuropathy and more likely to be something at the nerve root, which is what we'd call a radiculopathy. Our next pattern would be a mononeuritis multiplex. Now, if you break down the word, mono means one, neuritis is inflammation of the nerve, and multiplex is Latin for multiple sites. So you have individual nerves being affected, but not in a contiguous way. So meaning it's not a nerve directly next to another nerve. So you might have a median nerve involvement on the right upper limb, and then you have a radial nerve involvement on the left upper limb, with a tibial nerve involvement on the right lower limb. So those are individual nerves, so it's not strictly a mononeuropathy, but they're not really contiguous. They're not really touching each other. So with that, it makes it hard to put a single source as their problem. And so the definition you see on your screen is a simultaneous or sequential involvement of non-contiguous nerve trunks. And initially it's asymmetric, as I've just described, and it's usually acute or subacute, and it could involve both sensory and motor dysfunction. Another pattern that we sometimes see in peripheral nerves is the autonomic neuropathy, and this involves the nerves that are parasympathetic or sympathetic in origin. So a lot of autonomic neuropathies will give us non-voluntary, non-sensory nervous problems. Okay, so you'll have problems with continence. You'll have problems with maintaining blood pressure, so postural hypotension. You'll have problems with splanchnic vasculature and splanchnic innervation. So you'd have either loose stool for no particular reason that keeps recurring. You can also have genital autonomic neuropathy, and that's a very frequent thing that we come across, especially in diseases like diabetes. So patients with diabetes, if it's been long-term and now we're starting to get what we call microvascular complications, end up with erectile dysfunction, libido problems, and all these are considered autonomic neuropathies that are associated with the diabetes. And the reason we call them microvascular is because they get this autoneuropathies because of the diminished blood supply in the very small blood vessels that would be perfusing the genital organs. So because of that reduced blood supply, because of the diabetes, the long-term diabetes, they end up with reduced perfusion in their genital organs and to their genital innervation, and then you end up with an autonomic neuropathy. The last pattern I'll talk about is a neuritis, and as the name suggests, it's an inflammation of a nerve, and this would result in pain. It could also result in odd feelings, pins and needles, pricking, burning. It could also cause weakness. It could cause negative symptoms, so reduction in sensation, be it a numbness, be it just a reduction in sensation, even without the numb feeling. And it can also cause wasting and loss of reflexes. So as you can imagine, all these, because they're peripheral nerve, would have features of lower motor neuron disease. This is a very busy slide with a purpose, okay? The reason I made it look that busy is because, as you can see, nearly everything can cause peripheral nerve disorders. And as a fourth year, when you look at this, you're thinking, oh, so when Dr. Kwasa asks me what are the common causes of peripheral neuropathy, what am I going to say? Luckily for us, people have thought about this and come up with a pretty good mnemonic, which is dang the rapist, okay? So if you think about the mnemonic, you'll have covered nearly everything. So for the D, we have diabetes, one of the commonest causes of peripheral neuropathy. Alcohol, nutritional, so loss of B12, B2, Guillain Barre. Okay, remember we said because it's affecting the peripheral nerves, then it is a peripheral neuropathy. There's also trauma. All right, so trauma to a peripheral nerve can cause a peripheral neuropathy. The hereditary causes. Okay, I'll take us back to the previous slide so you can see some examples of these hereditary causes. Charcot-Marie-Tooth disease, a very prominent hereditary cause and very progressive. Okay, Fabry's disease, Tangier's disease, all these are hereditary causes of peripheral neuropathy. And then we have environmental. Now, when you think about environmental, drugs, toxins, even drugs that are not in toxic levels have been associated with peripheral neuropathy. We know for sure that in cancer patients who receive the vinca alkaloids, vincristine, vinblastin, that's a very, very common side effect. So in these patients, we start managing their peripheral neuropathy as soon as they have any form of symptoms, be it positive or negative. We know that the TB drugs, especially the isoniazid, causes a very prominent B6 deficiency. And so that's why all TB patients are put on pyridoxine, because they're going to be on isoniazid, which we know will bring down your B6 level and cause a very severe peripheral neuropathy, which if left for a long time is actually irreversible. So that's why we don't wait for the symptoms. As soon as we start TB treatment, you will notice every TB patient who is taking isoniazid, which in our guidelines is a baseline drug for the whole 6 months, will be on pyridoxine, 50 milligrams for the whole duration of their treatment. Likewise, when we think about drugs and toxins, lead, arsenic, mercury, these also cause a peripheral neuropathy, and it can happen for several years before it causes more severe disease. Rheumatic disease, such as rheumatoid arthritis, a very common cause of peripheral neuropathy. Amyloid, paraneoplastic. So you can just think nearly every cancer can present as a peripheral neuropathy. So when a patient comes in with strict peripheral neuropathy, your mind really is all over the place trying to figure out whether this patient has any one of these diseases. HIV itself can cause peripheral neuropathy. Varicella zoster can cause a very severe peripheral neuropathy of the painful type. And then once again, systemic disease, renal disease, liver disease, thyroid disease, lupus, although that ideally should be under autoimmune disease, and tumors. So if you think about the mnemonic, it helps you in your history taking. It helps you figure out how you want to investigate this patient, because we might not be able to look for everything in every patient, but we can look for some of the most common things, especially starting the history. If you have a history of heavy alcohol use, then that might be related to your peripheral neuropathy. And remember, the alcohol use does not need to be abuse. Okay, it is dose dependent because of the B1 depletion, which is the thiamine depletion. But even in patients who are taking a regular or a non-toxic dose of alcohol, because of genetic factors, they can end up with a peripheral neuropathy. That said, how do we evaluate a patient? So when we're taking the history, we're interested in certain things. Is it more distal? Is it more proximal? So patients with motor disease tend to have either very distal or a very proximal peripheral neuropathy. Now, when we think about a proximal peripheral neuropathy, we're also going to think about involvement of muscle. So we'd also look for myopathy. In patients with more sensory symptoms, we'd look for whether it's positive or negative. We'd ask them what they experience. Is it more numbness? Is it more lack of feeling? Or is it more positive symptoms, burning, pain, tingling, pins and needles? Or are they having autonomic symptoms? Do they feel very dizzy when they get up? Are they having erectile problems in males? Are they having libido problems in females? Are they having unusual sweating or inability to sweat? Are they having, in diabetics, are they having unusual loose stool for no particular reason? Nothing has changed about your diet. You're not, you don't have an infection, and yet you just have these frequent bouts of loose stool. We then look at the time course. So we want to find out, is it acute? Or is it subacute? Or is it even chronic? So in acute peripheral neuropathies, days to up to maybe a month, we're thinking of things like a vasculitis. These will be quite dramatic in their presentation, and it will just be days. If we're thinking more subacute and chronic, so it's been there for a long time, this is more common, and we think about all those other causes on the list, including things like chronic inflammatory demyelinating polyneuropathy. So CIDP is not the only thing. I'm just telling you, most peripheral neuropathies are going to be chronic in their time course. We then look at the distribution. So is it motor? Is it sensory? If it's motor, is it in one place? Is it a mononeuropathy, like we've already talked about? Or is it quite symmetrical? Is it more proximal? Is it more distal? When we're thinking about sensory neuropathies, we're wondering about what sort of fibers are affected. We remember type C fibers. We remember how to examine for these things. So if it's the small fibers which carry mainly pain and temperature, then when you assess using the pinprick from neurological exam, is that affected? Is it affected in a very symmetrical pattern? When we're thinking more of larger fibers, then we have involvement of the posterior columns, which would be your joint position sense. You remember how to examine for that in neurological exam, or your vibration sense, using a tuning fork, preferably a 128. So when we're taking a history, you want to ask the patient, where do you feel this numbness? And ask them to show you, to point at it, not just take their word, because now we know that since we have anatomical words, a patient's description of a leg might actually mean their thigh muscles. So don't take the leg to mean leg. Ask the patient to show you where they feel these symptoms. And likewise, when you're presenting to me, if you present and tell me the patient had burning in the legs, I am thinking anatomically, because I expect you to be using anatomical terms, as opposed to if it's the whole lower limb, if it's just the leg, if it's the foot, if it's the sole, all these are anatomical regions. When you're taking a history, you want to find out about whether there's history of toxin or infectious exposure and what these toxins could be. Are these patients who work in the paint industry? Do they work with chemicals? Do they work on farms? Or have there been infectious exposures? Are these patients who've been around people with TB, or whether they've recently suffered any form of febrile illness, or whether they have features that might suggest HIV. Maybe they've gotten a Bell's palsy in the past. Maybe they know their status. So these are important questions to ask. And then you want to take a family history, not specifically related to the peripheral neuropathy, but maybe to diseases related to the peripheral neuropathy. So if this was a hereditary peripheral neuropathy, like we talked about the Charcot-Marie tooth or the CMT, it would be quite evident in the family that there are other family members with it. Although because it's autosomal it's autosomal recessive, there might be a skip of generations. So this might be the first patient presenting. So remember, a lack of family history doesn't mean a lack of diagnosis. It just tells you what sort of inheritance it might have been. Likewise, if there's a strong family history of diabetes, and this is a patient over 40, then if they're presenting with burning in their feet, you do need to think about diabetes, because the peripheral neuropathy in diabetes can present well before your sugars even become abnormal, up to years before the sugars. So it might be the harbinger of something that's coming. Medications, a very important part of the history. Whenever I'm taking a history from a patient with peripheral neuropathy, I ask them to just keep naming all the drugs they can name. And remember, when patients hear, are you on medication, they want to just tell you the ones that have been prescribed. But remember, this is, in modern times, we have a lot of access to medication, even without a doctor prescription. So you can be on supplements. B vitamins, especially B6, can actually worsen a peripheral. It has a toxicity that causes peripheral neuropathy. So B6 is a very interesting one. Its lack of it causes peripheral neuropathy, and its toxicity causes peripheral neuropathy. So you need to be really somewhere in the middle, like a Goldilocks effect, not too hot and not too cool with B6. So you need to ask about medication. And what I usually ask is just to ask the patient to show me all the medications they have on their phone, because they won't remember the names. But in the age of Google, everyone wants to find out what the doctor or what they're taking, and they'll have Googled it, or they'll have taken a picture of it to Google it later. And then you want to ask about systemic disease. Now, of course, you don't ask the question, do you have systemic disease? You look for it. Have you ever been told your blood sugar is high? Have you ever been told your blood pressure is high? Have you been encountering facial puffiness in the mornings? Has your urine habit changed as you look for renal disease? Have you had periods of yellowness of the eyes to look for liver disease? Have you had abdominal distension to help you figure out, could this patient be going through a liver problem? So as you can imagine, the history, because of all those patients and all those reasons for peripheral neuropathy, is very, very wide. So what do we do when we examine? We want to examine for pattern and for localization. So you want to see, is it just one nerve or is it many nerves? So you want to figure out if it's focal or if it's a polyneuropathy. You also want to look in terms of, is it predominantly motor? Is it sensory? Or is it autonomic? And you do these in different ways. So if it was predominantly a motor problem, then they'd have weakness. You'd assess for power. Okay. If it was predominantly sensory, you'd assess the sensory modalities, the pinprick, the light touch using cotton wool, and vibration sense with the tuning fork, as well as joint position sense. So that would help tell you which areas or which patterns of sensory involvement are involved. If it's autonomic and this patient has been describing dizziness, postural dizziness, then it behooves you to take a blood pressure both in sitting and standing or in lying and standing positions and look for a postural drop, because that will help you clinch a diagnosis of a possible autonomic neuropathy. And then if we're looking at the sensory, then you want to figure out, is it affecting just one type of fiber, small fibers, which would affect mainly pain and temperature, or is it affecting several different fibers, which is not just pain and temperature, which you'd use a pinprick, but also your vibratory sense, which you'd use a tuning fork. Sometimes we have loss of reflexes as well when we have large fiber involvement. So in patients with long-standing diabetes who have progressed from small fiber to large fiber involvement, you have a reduction in their knee reflexes and probably even absent ankle reflexes. So that simple examination, tapping on a reflex in a diabetic, can tell you a lot about whether they have microvascular disease, which would cause things like peripheral neuropathy. The next thing you want to look for is signs of other disease. Remember, we've said paraneoplastic, so you're looking for lymphadenopathy. We've said liver disease, renal disease, so you're looking for some form of organ enlargement. And then you're looking for muscle and joint abnormalities, which might suggest that this patient has more. If they have Charcot joints, then we might be talking about an autoimmune disease, which also gives you a peripheral neuropathy. If they have a skin rash or a pes cavus and hamartomas, that might tell you that this is more likely to be hereditary, something like Charcot-Marie tooth, or something like diabetes, which is long-standing as well. We move on to, are there some form of foot deformities? Because these lead us a lot to hereditary causes. If we see very thick nerves, then we might be thinking of other diseases like leprosy, Refsum's disease, amyloid. Charcot-Marie tooth can also give you nerve thickening. When we have large fiber neuropathies, like we've said, with loss of vibration sense, we'll have things like problems with darkness. So when you take away light, because our sense of position is not just visual, it's proprioception, and it's hearing, the vestibular component of hearing. So in patients with vestibular disease, they get very imbalanced. In patients with proprioceptive problems like peripheral neuropathies of large fibers, they get very imbalanced. And of course, in patients with visual problems, they have trouble with balance. So a large fiber neuropathy can give you imbalance. The presenting complaints could be false. It's up to you to try and figure out which part of, all three might be involved in this patient with imbalance. Small fiber neuropathy might give you impaired pain and temperature, but the reflexes might remain perfectly normal. So you tap on the knee reflexes, you tap on the ankle reflexes. And the reason I'm talking about the lower limbs is because long fibers are affected first rather than shorter fibers. So because our lower limbs are much longer fibers, it tends to affect lower limbs first before upper limbs. In autonomic neuropathy, I've already talked about taking a blood pressure. If you suspect autonomic neuropathy, you look for a postural drop. So you take the blood pressure in both the standing in supine or standing in sitting. Ask about things like impotence. Ask about bladder and bowel dysfunction, and look for pupillary responses. So in patients with autonomic neuropathy, like say due to syphilis, you can get an Argyll-Robertson pupil. So that means your accommodation reflex is lost, even though you have a light reflex. Some clues to demyelination would be a postural tremor when you put out the hands, or would be an areflexia, not just in the longer limbs or in the longer nerves, but generalized. And likewise, when we have demyelination, we have much more weakness and wasting. So the patient is very, very weak and almost unable to stand without an aid. But when you look at their fibers and their legs and their muscles, everything, well, you can't really look at fibers, but their muscles and their legs, everything looks really quite preserved. So that should tell you that this peripheral neuropathy is more likely to be demyelinating rather than axonopathic, because in axonopathic patients, you'll find that there's a lot of wasting that corresponds with the level of weakness. This is a very busy slide, and the reason I've put it here is not to make you afraid or fear, but it's to let you see that, that there are so many different causes and considerations when we examine a patient with neuropathy. So I'm not going to go into any details, but you'll see some recurrent themes here. Diabetes, HIV, diabetes keeps coming up. B6 deficiency comes up. Okay, amyloid, porphyria, GBS. So these are different considerations when we're talking about peripheral neuropathy. So don't worry too much about this table. How do we investigate? Now, remember we said that nearly everything can cause a peripheral neuropathy, but we can't investigate everything. So we do what we call baseline tests. And I like to divide them into tiers because there's some things that we need to do in everything or in everybody who presents with the peripheral neuropathy. And then there's some that if you have a high index of suspicion, you can move on to. So I would consider B12, folic acid, liver, kidney function, blood sugar would be basic tests, what I'd call first-line tests. A first-line test would also include things like a full blood count and ESR to tell us if there's any form of infection or if there's any signs of chronic autoimmune disease. Also, an ANA would probably be what I'd consider first line. Now, if all these are negative, then we might not even need to move to more second-line tests, which would be looking for more paraneoplastic things. So we look at antineuronal antibodies, we look for sarcoid, we look for Lyme's disease and HIV. Maybe I should have put the HIV as first line in this setting. And then if these are not suggestive, we move on to more specific tests. And a lot of times, I'm going to tell you this here and now, we don't get to third line tests. One, because of the cost, and two, because if your index of suspicion is not high, then we don't need to look for cryoglobulinemia, okay? That would be useful if this patient had a very acute and very painful sort of presentation, because we've said that is very likely to be vasculitis. And in those patients, I'll go further and ask for things like Hep B, C, and cryoglobulins, as well as a complement look. So we don't do this in every patient, and that's why I've put it like this, so that you remember that this first line, if this isn't seen, then we move to second and third line. And by the time we're moving to second and third line, this is a patient, ideally, you should be referring to a neurologist. Nerve conduction studies, very useful when done for the right reasons. So nerve conduction studies help us differentiate between demyelinating disease and axonal disease. And I've already described that demyelin is like the covering, axon is like the actual electrical wire. So they also help us distinguish between hereditary and acquired disease. And, oh, I'm sorry, I will mention that, Ali, okay? I'll come back there. So they also help us detect whether asymptomatic abnormalities are present, and this can be very useful in patients who have paraneoplastic disease or vasculitis. They can also help us distinguish whether we have a very symmetrical length-dependent or an asymmetrical patchy look. So I'll answer your question, Ali. ANA is anti-nuclear antibody. I'm really sorry about that. I shouldn't have used those abbreviations unless I'm going to talk about them in full. ENA is extractable nuclear antigen. dsDNA is the double-stranded DNA, which helps us, is more specific for lupus. And what was the last one I put there? Serum protein electrophoresis would be useful. Okay. All right, good question. So radiology. Not every patient needs a radiological investigation. In fact, very few need. Unless you're thinking about something like sarcoid and malignancy, maybe I might ask for a chest x-ray. So this isn't a routine investigation, okay? An MRI, if you're thinking this is really quite symmetrical, well, it's not symmetrical, but it's contiguous and it's on one particular limb, and that's unlikely to be due to diabetes. We need to think about the plexus, okay, brachial plexus or lumbosacral plexus. And in those sort of things, we might need imaging using an MRI. Likewise, CSF is not routine. It would help us try and figure out if there's some form of demyelination going on in the central nervous system and in the peripheral nervous system, because we'd pick out things like oligoclonal bands, or we'd be able to pick out malignant cells in patients who seem to have a neuronopathy. Nerve biopsy, and this is why I put it right at the end, is really a test that should only be requested by people in subspecializations. I don't even request them because it would only help me distinguish very specific types of peripheral neuropathies. And that is not something that I am going to manage. So that is a test that I let people with expertise in peripheral disorders request, because otherwise we can pluck out your sural nerve any day, but how useful will it be for me? So a nerve biopsy is really more of a specialty specific request, but it's good to know that sometimes they can be done. They're very useful in distinguishing different types of vasculitic neuropathy or in making a certain diagnosis of amyloid. So in 4th year, in 6th year, even in MNED, I don't expect you to be picking out people's nerves. So what are some common entities? So diabetes, we've said it's one of the common causes of neuropathy. It's the most common cause of neuropathy, actually. And you can have different presentations. You can get a polyneuropathy, like we've already discussed. We can get a cachectic neuropathy, which is a very painful one, okay? We can have an insulin neuritis, meaning people who are on insulin get unusual pain on the specific sites where they inject. You can have a lumbosacral radiculoplexus neuropathy, so it's right at the nerve roots. You can have mononeuropathies. People with diabetes frequently have carpal tunnel, or you can have cranial neuropathies. People with diabetes also frequently get Bell's palsy. GBS, another common entity. So the thing about it, like you remember, it's more of an ascending, it's predominantly motor, can progress to respiratory involvement. So that's the real danger with GBS, is that it can ascend quite quickly over days and give you respiratory failure. It may be preceded by a GI infection, which is Campylobacter or Epstein-Barr virus, or even a cytomegalovirus. There are different variants, okay, of GBS. So some of them even have a sensory component. We won't go into that at this level. The diagnosis depends on having a CSF examination, which should have a very high protein and very few cells. So this is what we call the albuminosynthetase cytologic dissociation. So usually in patients with high protein in CSF, we expect you to be having a cellular reaction. But in GBS, you get a dissociation. So the albumin or the protein and the cytology or the cells are not moving together. So you have a high protein and very few cells. We also make a diagnosis using the nerve conduction study. And lastly, if we're able to do the antibodies, the anti-GM1 and anti-GQ1B antibodies can help you diagnose GBS. At your level, it's important to just remember that a CSF with albumin or cytologic dissociation is very suggestive of GBS. HIV, another common cause of neuropathy, and the presentation can be, just like diabetes, quite different. It can give you a very distal and symmetric polyneuropathy, what we're calling a DSP, or it can give you a very radicular, neuropathy. So it would be the lumbar sacral area and it would be the nerve root. So it can be on one particular limb, really quite painful. And this can happen when you have an associated cytomegalovirus infection. It can also give you what we described as mononeuritis multiplex, or it can give you a GBS picture, an acute inflammatory demyelinating polyneuropathy. The older drugs used to cause a mitochondrial toxicity, but luckily for us, we're no longer using these drugs in HIV. The risk factors for HIV neuropathy would be males. I'm sorry to all the men. A high viral load, alcohol use, like we've said, older age, the D-drug exposure, and of course, comorbidities. Just because you have HIV doesn't mean you won't have diabetes. So with that, I'll end. I'm happy to take any other questions that you may have. Either you can put them in the chat box, or if you want, you can unmute. All right, so Machage is asking us to explain diabetic cachectic neuropathy. So, as recording the name suggests, stopped. The cachexia is it brings in the fact that with diabetes, sometimes you end up not just with a neuropathy, due to the microvascular disease, but you also end up with muscle wasting. So in these patients, they'll look, and it might not be very symmetrical. So you might have a limb that looks quite unusually thinner than the other. So if it's on a lower limb, maybe the thigh muscles look much thinner on one side than the other, and they might have a lot of pain. So in these patients, you'd look and say, okay, so there's a difference in size. So it might not be just a purely muscular problem because they also have a lot of pain. So it's both muscle and nerve. And that sort of cachexic neuropathy is also sometimes called amyotrophy. Diana is saying, if a person suffered from GBS and gets muscle wasting, is the muscle wasting reversible? Absolutely, because GBS is a very acute presentation. Things are, remember, nerves are very, very slow. You can't hurry nerves, If you remember from your physiology, it takes about, how long was it? It takes about a year for a nerve, or is it a month for a nerve to grow by a centimeter? I've forgotten those details, So when you've had GBS, because it's a very acute presentation, it takes a while to heal, but as you recover, because the recovery from GBS can take years, As you recover, your muscle changes will improve. So yes, it is reversible. Niharika asks, the pathologic mechanisms, what did motor neuron disease, MND meant motor neuron disease. So neuronopathy means it's either affecting anterior horn cells, like in motor neuron disease or MND, or that's what a neuronopathy is. So something that's affecting anterior horn cells. Right? It's difficult to pick out from history, so these are more things we pick out from nerve conduction studies. All right, GBS investigation. So investigation of GBS at your stage should include CSF. And when you look at the CSF, you will find a high protein, but with very few cells. Okay, so that's what we're calling an albuminocytologic dissociation. Usually in patients who have high CSF proteins, we know that there's some form of reaction going on, an immune response, and so they will have a lot more cells in their CSF. So in patients with GBS, they'll have these high proteins, but not a significant increase in the number of cells. So that's what I called an albuminocytologic dissociation. At your level, I think just knowing about the CSF is enough. As you go higher, we will also learn that we can use a nerve conduction study to investigate Guillain-Barre. Fiona is asking, re-explain mononeuritis multiplex. So mononeuritis multiplex, as the name suggests, it's mono, so it's a single nerve. Neuritis is an inflammation, and multiplex means it's at several different places happening at the same time. And they're usually not contiguous. So you might have one nerve in the right upper limb, which could be a median nerve involvement. You might have one nerve in the left upper limb, which would be a radial nerve involvement. You might have another nerve in a lower limb. So they're non-contiguous, meaning they're not touching each other or they're not next to each other, and yet they're involved. So that means it's a mono, okay, single nerves. There's inflammatory, okay, and it's in different sites and it's happening at the same time. I hope that helps. I think I can see one more question, I think. No, I think that's it. All right, so assuming I have captured all the questions, I'm just going to look through one more time. Yes, I've captured all the questions. I'm going to thank you for your time. And God willing, I think I'm covered because next Tuesday, I've given the next Tuesday slot. Like I said, I won't be doing CNS neoplasia. I'll let the surgeons deal with it. They'll deal with it in a much better way. Okay, so thank you once again for your attention.